Hello, everyone. Good afternoon, and thank you for attending our session. And on behalf of the European Health Telematics Association, I would like to thank also the organizers for allowing us and inviting us to host this interesting session. I'm George Tafoulas. I'm a trained physician in internal medicine, and I work with digital health more than 10 years. I served this year as medical officer of EHTEL. EHTEL is an association almost 20 years old, and it represents a lot of industrial research and various health providers, but also individual members that work on the digital health in various sectors, predominantly, of course, telemedicine. It's also the topic of this conference. Some practical aspects of this session: I will be introducing two speakers that will give a presentation of 50 minutes each, which are pre-recorded for practical reasons. And the second part of the session will be interactive participation and debate with them and invited commentators, and will be coordinated by my colleague in EHTEL, Diane Whitehouse. I would like to welcome your input as well. So please send your questions or opinions to be discussed during the presentations, and we'll debate and discuss upon them during the second part. The case study we have selected to present is chronic heart failure within the hybrid model topic. Chronic heart failure is one of the major chronic diseases that causes a lot of burden for the health systems due to often exacerbations, and sometimes they're very dangerous for the life of the patient, not only the clinical setting. For that case, telemedicine has been proposed, and European Society of Cardiology was one of the first medical professional associations that introduced guidelines for telemonitoring of these patients. The latest one in 2016 already suggests structured telemedicine support, structured telephone support, as long as invasive telemedicine for some cases and group of patients. However, the new norm that the fourth industrial revolution introduces is the hybrid care model, where ICT telemonitoring and interventions can be combined with classic routine care. And we have then what the literature says, hospital at home cases, or even sometimes more advanced treatments. So we have selected this case study for these reasons, and I would like to thank the two participants and we have the privilege to host today as invited speakers. So I believe we can start now with Julie from Belgium, and then the pre-recorded presentation of Astrid will follow.
Good afternoon. I would like to address this talk on how digital technology could meet home hospitalization care, and this through the patient's eyes. So let's start off with the patient. Meet Hugo. Hugo has been diagnosed with heart failure several years ago, and he suffers from acute episodes of decompensation several times a year. He used to be a primary school teacher at a military base, and he lives his life to the fullest. He used to be very independent and very active, but because he suffers from those acute episodes of decompensated heart failure, he also gets hospitalized quite frequently. And he thinks of these hospitalization as a burden, as uncomfortable, and the only thing that he really wishes is to be home as soon as possible. So what if it would be possible that we could provide the same quality of care as in a hospital, but then within the home environment? And that was our intention when we set up the NWE Chance project in 2018, where we want to develop and validate promising integrated e-health applications to enable home hospitalization of heart failure patients. We do this within a lovely consortium consisting of clinical partners such as Isala Hospital in Amsterdam, the Maastricht University Medical Center in Maastricht, and Jessa Hospital. Technology is provided via SanaNet, Sensium, and HE at home. And to form this hybrid care model, we also receive support of the partners of EHTEL, B, University Hasselt, and DHI. Now, what does this hybrid care model look like? So, of course, we have the patient at home, and the patient will be visited by a nurse on a daily basis. It is important that the vital parameters and other parameters are also monitored by the technology. So this could be a blood pressure monitor or a oxygen saturation meter or a weight scale. All of this data should be contained or should be summarized on a cloud-based platform, which can be accessed by the healthcare practitioners such as the cardiologist or the nurse. And this platform or this dashboard will provide a direct overview of the patient's progression. But what is essential within this hybrid care model is that it is patient-driven. So the patient should experience the best of both worlds. They should experience the humane contact of having specialized nurses and cardiologists, but they also should be supported by technology to the fullest. And this technology should be easy interpretable, easy to handle, and easy to understand. Now, what is so essential also in this hybrid care model is that it is a home hospitalization for a longer period of time. So it's not a short spot check measurement or using remote monitoring. It is home hospitalization that can extend for several days, which means it's very important that when we rely on this technology, the data should be of high resolution, because this data will allow us to give insights on the disease progression of the patients and should enable us to provide efficient and quick responses when needed. Now, how does this technology look like? First off, we start with a wearable patch, which is worn on the chest and measures the vital parameters such as heart rate, respiration rate, movement, and posture every few minutes. There is also a kit which contains a blood pressure monitor, a weight scale, an oxygen saturation meter, and a step count device. The patient also receives a smartphone application. First off, this consists of two parts, being the app which will summarize all of the essential data for the patient, being his vital parameters, his blood pressure, and so on, but will also contain an e-coach. And this e-coach will really try to provide or ask of the patient contextual information like symptoms check or fatigue. Of course, like I said before, the patient should experience the best of both worlds. So the dashboard or the clinical platform will allow the nurse, the specialized nurse, to visualize this data, to visualize the progression of the patient, and will use this information when she uses this information to go on the daily visits. This enables her to easily change medication or IV therapy. The clinical platform should be easy accessible and easy interpretable for healthcare practitioners as well. So this is an overview of how data is summarized from the wearable patch, as well as data that is used or provided of the weight and the blood pressure. Now, during the NWE Chance project, Hugo was part of the home hospitalization process. And of course, it is very important to know how the patient experienced this. And he says his experience was great. He loved it. It was comfortable. And everything within the approach was easy understandable. He even says that when possible, he would definitely want to make use of the home care services or home hospitalization approach again in the future. He also emphasizes that he found it very important that the technology was easy to use and that he felt safe because the technology provided a nice overview for him, but also that data was shared with his nurse. He even said that he believes we should rely even more on the technology because he thinks it would be okay if you wouldn't see the nurse on a daily basis. So what about the specialized nurses? Well, their opinion was that they were wildly enthusiastic and they think that home hospitalization should be part of the future. And even though hybrid care is still in its infancy, this allows us to make more room for technical and organizational improvements. And hybrid care, as I said before, is the best of both worlds, using both technology and using the expertise of the nurses to enable swift and qualitative care and to enable rapid decision-making. Also, the nurses believe that we should embrace and rely even more on remote monitoring and home hospitalization and really take this a step further. So what could be the future of hybrid care? The future could be, like I said before, we should rely even more on remote monitoring to enable this home hospitalization and to make decisions more quicker and really rely on the technology itself, but not forgetting the humane aspect. This project itself could be or could serve as an example for other care paths that could benefit from home hospitalization as well. As an enabler, this could serve to enroll home hospitalization at a large scale, but never forgetting that it should be the best of both worlds. I thank you very much for your attention and be happy to address some questions.
Good afternoon, ladies and gentlemen. My name is Astrid van der Velde, and I am employed as manager of the cardiology practice at Isala Heart Center in Zwolle, the Netherlands. Furthermore, I'm project leader of NWE Chance. And Julie Vranken, our previous speaker, has already introduced NWE Chance to you and its hybrid care model. And during this presentation, I would like to focus on the organizational implications of home hospitalizations. Analyses have shown that up to 46% of the hospital care could be provided at home. And with that care, we mean digital health or via hybrid care. That means traditional in-person care combined with digital health. And although the last years we have seen that ambulatory care is provided at home more and more, and we are talking about teleconsulting, telemonitoring, telerehabilitation, what we also see is that the hybrid care model of home hospitalizations is still in its infancy. And in 2005, we conducted a pilot at Isala Heart Center with the admission of heart failure patients at home. And the pilot demonstrated that it was safe, effective, feasible, and also patient-friendly. Up until recently, however, this was still a local initiative. Why? This has everything to do with the organizational implications, with a great amount of organizational implications. We are talking about providing hospital care at home. We are dealing with complex logistics. There are several questions around the area of human resources. You need to think about what personnel could you let go to the homes of the patients. What are the roles? What are the responsibilities of the care professionals? You also have to deal with a number of technologies, with a number of legal issues, and with finances. And I will use our NWE Chance project to share how we implemented home hospitalizations and also share the lessons learned. Within NWE Chance, 3 hospitals are involved. That is Isala in Zwolle, the Netherlands. That is Maastricht University Medical Center in Maastricht. And that is Jessa Hospital in Hasselt, Belgium. Those locations are depicted in the map over here. And what you also can see is that the hospitals are, in geographical terms, quite close to each other. 236 kilometers at its furthest and only 34 kilometers at its closest. And still, what we are observing is a great amount of differences in the implementation of home hospitalizations. And that has to do with the fact that we are dealing with different countries, but also with different local habits. Then we will focus on the organization of care. What is important to mention is that it's a complete different concept, providing clinical care at home, providing clinical care at the hospital. Normally, the patient comes to the hospital. Now, the hospital, the nurses, comes to the patient in their own homes or in the living environment like a nursing home. That means that it is important to have clear criteria on how to select suitable patients. In our case, our heart failure patients are already known in the hospital and are well characterized. We work according to strict in- and exclusion criteria, and we also have a discharge procedure. We work with specialized nurses. In Maastricht and in Hasselt, they use heart failure nurses. And in Isala, we use intensive care and critical care nurses. The nurses work according to standard operating procedures, and they work under strict supervision of the cardiologist. The introduction of this form of hybrid care also means a shift of responsibilities. And it also affects the skills that are necessary to perform such work. For instance, the doctors need to have digital skills, and they should be able to coach a nurse on a distance. The nurse, on the other hand, needs to do independent decision making and must be very flexible. Because we are dealing with hospital care, we need to provide a 24/7 service. That means that within working hours, in Maastricht and in Jessa and in Isala, the specialized nurse can go to the home of the patient or can be called. And in the evening, night, and during the weekends, what we see is that in Jessa and in Maastricht University Medical Center, the patient can call the cardiologist on duty, and in Isala we have a 24/7 a specialized nurse on duty, and in some cases they can rely on the cardiologist on duty. Well, we are dealing with hybrid care, so a lot of e-health is involved. And that means that we also have a help desk to support the patient and the nurses at home. In case a patient experiences a problem with his patient app, then the patient will contact the nurse. And the nurse can contact the help desk. And I will explain a little bit more about the organization of this in a few moments. Furthermore, quality management and safety is of utmost importance. So we register adverse events until 30 days after discharge. Let's have a look at the technology. Julie has already explained a little bit about this. We have made an integrated home hospitalization platform with a patient app and with a web portal because we needed some more efficiency. It is not very handy for the care professional, for the nurse and for the doctor to have several different technologies with several different displays. So nowadays the nurse has one web portal. And the technology is integrated in such a way that we can do front-end integration and back-end integration, basically all kinds of integration you can imagine. And that means that the system is very flexible. So we can add technology, we can remove technology. And the technology is also developed in such a way that it can communicate with the electronic medical records of a hospital. We are also dealing with some legal issues. What you can see over here is a part of the application programming interface of the technology. Please don't read what is on your screen right now. What is important are the arrows. The arrows show data communication. And please remind, this is only a part of the data communication. And we are dealing with sensitive patient data. So we need to comply to the General Data Protection Regulation. We also need to have CE marks for the technology used. And we need to have proper arrangement about the intellectual property. One other hurdle is finance. It is very important to show that the care model is effective and also cost effective. For this, we use the MAFEEB tool. I also put the website of MAFEEB online. It's an open and free tool. So if you're interested in cost effectiveness for a new intervention, care intervention, please have a look at that. But even if your model is cost effective, it doesn't mean it will be reimbursed. And also here I displayed the organization of the health system in the Netherlands with all stakeholders involved. And please compare this to your own situation in your own country. Then you will see that the healthcare funding system is so different per country and even within one country. So during the implementation of our pilots, we are learning a lot about the organizational implications. Well, the pilots are still being conducted, so we are still learning. But at the end, we will capture our lessons learned and crucial elements into a blueprint. So the blueprint will include roles and responsibilities of the nurses and the doctors, standard operating procedures, 24/7 service, logistics, and quality management and safety, but also the technical environment, the legal requirements and finances. But we are not there yet. However, I do want to share the lessons learned with you. Please start with a well-defined patient pathway. Also start with the patient and not with the technology, an error often made. Keep in mind that the service must be scalable and provide a 24/7 service. We are dealing with hospital care. Embrace the couleur locale, which means have a look at your local situation. If, for instance, you have a good bond with home care, please make use of that. Secure the legal and administrative aspects with respect to the use of novel technologies. So that means data processor agreements, that means clinical trial agreements, data transfer agreements, etc. Display the effectiveness and also learn from others. And with respect to that, at the end of our project, we will launch an innovation hub to bring together stakeholders in the field of home hospitalization. And we will share, among others, our blueprint over there. So if you are interested, please keep in touch via our website or via our socials. Thank you very much for your attention.
So hello again. Thank you for your attending the previous two presentations, and thanks to the speakers for their interesting input. But we're honored to have them live now, and the audience seems to have already interacted with questions. And so I pass the floor now to my colleague from EHTEL, Diane Whitehouse, the eHealth Principal Policy Officer. So please, Diane.
Thank you very much, George, and hello to everybody who's with us today. We do indeed have 3 or 4 very straightforward questions that we're going to pose to our 2 speakers. I do also want to acknowledge the presence of Stefan Buznatu today, who was our keynote from the very first session in the conference. So I think Stefan will also jump in there at times. Astrid and Julie, our attendees are interested in, are there any patients with comorbidities rather than just heart failure, and how does that affect what you're doing?
Thank you, Diane, for the question, and also the audience for the questions. Indeed, a very good question. We can admit patients with comorbidities at home. However, it depends on the type of comorbidity. In case a patient also needs hospital treatments from another specialty related to the comorbidities, in that case, a patient can't be admitted at home. Also, what is important, sometimes a patient also needs an operation in the hospital within the near future. In that case, we also don't admit a patient at home. But if a patient needs has comorbidities that require treatment from a general practitioner, those patients often can be admitted at home.
I know you're both very interested in safety issues, and one of our audience speakers has asked about what happens in the case of emergencies. Do you have any particular protocols, to use the clinical term that you use there, for heart failure?
I think it's already very important to stress out for the patients, or to educate the patients from the beginning on, to let them know what they should do when they are not feeling safe. I also believe, or one of the protocols should be there, that patients should contact the ER department when they are feeling unsafe or when they experience heavy symptoms. Because we also stress out with this home hospitalization is that there is constant monitoring, but there is not constant alarming or thresholding and so on. So even though the patient might experience symptoms, it should be educated to the patient very clearly that he should intervene also for himself when he is feeling unsafe.
Mm. Do you see any implications, Astrid, at any other point in time in the patient's journey?
Well, I think what is important to add is that the hospitals also have good connections with the ambulances. So the ambulance service knows that we are admitting patient at home, and also know what to do in case either the patient or the hospital calls the ambulance for the patient.
That point, I think, about the link up with the emergency services is surely very important there. Do you see that also, Stefan? I know you weren't making a presentation here, but do you see that on your side too?
I think it's a very interesting discussion, and somehow for the audience to better understand, when we speak about home hospitalization, we need to take into consideration that the heart failure pathology has different classifications. So generally speaking, it is graded from class 1 to class 4. And I would presume that in these cases, for these patients, they would go for intermediary classes of in terms of telemonitorization, because for sure, if we speak about class 4 heart failure, it is when the patient is having extremely heavy symptoms, then for sure it needs hospitalization. And the key idea is that if you know exactly what is the status of the patient, so you know if he's a class 1, class 2, or class 3, basically by ensuring this telerehabilitation, telemonitoring model, as to say, you keep the patient in a steady status. So you don't get to a class 4 and you can manage him, even if it's in class 2 or class 3, from at home. And this is the most important thing, because if we speak about emergency situation, of course, there can be emergency situation, because when a patient that has heart failure also can have a myocardial infarction in time. And this is an urgent situation. And then it comes into connection with the emergency service that is available nationally, because it's another condition that basically aggravates the pre-existing heart failure.
One of our audience members, and it might link with this, has asked us what happens if a patient is in a comative state. Is that, can this model also work in that kind of conditions? I guess it's much more about consent issues there, and how you handle a heart failure patient when there's an emergency.
Well, with respect to comative patients, we don't admit those patients at home. We are all focused on heart care and with a direct consent from the patient. But that doesn't mean that it won't be possible in the future. But then, and that's actually quite interesting, they need to have a look at the system as a whole. Because if a comative patient needs, for instance, frequent in-person treatment, in that case, hospitalization at home doesn't seem suitable. But in other cases, it might be. That's something for further investigation, I would say.
Thank you very much indeed. I'm now going to take the conversation up a level a little bit. We will keep looking at the chat box and bring on board questions. But first of all, we'd like to remind everybody that NWE Chance has just successfully put out a white paper that's all around these topics. It was launched today. I will put that in the chat box. Yep, just in case people have missed it. But that's really a good point of reading, a good source of information for people who want to know more about hybrid care, how it works, and what Julie, Astrid, and Stefan are talking about. I'd like to take us to the level of three very kind of basic questions. One about organization, one about technology, and one about economics or the budgetary issues. And maybe starting with Julie first and coming back to this really critical, important issue of safety and security, and that patients' health conditions don't always develop as you might expect them. Indeed, one of our audience members was interested in what happens with discharge up to about 30 days after leaving the hospital. But do you think there's one key, really important organizational issue that it's really important to get right, so that the patients really do feel safe in their own homes with this kind of treatment? Julie, I'll throw it out to you first, and we'll go Julie, Astrid, Stefan.
Thank you for the question. And I do believe that there are several key elements. But first of all, I think that most important element would be communication. In order for patients to know what is expected of them, but also for the nurses and the cardiologists, every caregiver or informal caregiver who supports the care model should be well educated, and they should be communicating very well in between each other. The thing that you want to avoid is that patients feel like a big brother is watching them. That's the thing you want to avoid. And by communicating clearly on what the technology does, and also about the humane aspect of the entire model, I think those are really key features or key elements that are part of this hybrid care model that you always should take into account.
This is really interesting, is it not, Astrid, in terms of them building a list of kind of key elements that need to be in place for hybrid care to work well? I know that Julie just essentially mentioned 4 elements there, but I'm sure there are additional things that you would like to add, perhaps. Astrid.
What is actually interesting in this question is might be a difference between the perceived patient safety by the patient themselves and by the more actual patient safety. With respect to the perceived patient safety, what we experience is that the communication, what Julie also mentioned, between the nurse and the patient is of utmost importance. So you need to have qualified personnel there, trustworthy nurses, which can communicate very well with the patients. What also helps them is the support of the family at home. If they are reassured with the concept, it helps. And what you also see is the real-time techniques, the monitoring of the vital signs reassures the patient. When we have a look from the other side, from the hospital point of view, quality management is of utmost importance. And with quality management, there are several aspects there. We mean the qualified personnel. You really have to, for instance, when we started with the pilot in Isala, we used the trained intensive care, critical care nurses. Why? Because those nurses are used to do independent decision making. And so that helps. What is also important that we know the patient, that it are well characterized patients, that we use strict inclusion criteria, and also that we provide 24/7 care. So those are all elements with respect to quality management that are very important for the patient safety.
I guess collectively you're perhaps developing a list with priorities, and maybe you're moving towards a set of guidelines that can be introduced to people. Stefan, what's your experience in Romania on this organizationally, or perhaps in terms of what the technology issues are here?
I think Astrid somehow put all the things on the table, and if I draw a conclusion or a summary, I would say that in this part related to the qualification of the medical personnel in terms of digital health tools, and also in terms of the treatment of the disease that they need to follow and need to monitor, it's the most important thing into building this system. If we speak about cardiology, basically at the moment we know that we have all the information that prove that telemonitoring reduces mortality, reduces hospitalization rates, and we have all these figures. So the problem is that I think in the med schools, because I'm speaking also about the education that is provided in the med schools, it hasn't entered this concept of digital health well enough in order to prepare the future students that will become doctors or will become nurses to be specialized and to use the telemedicine tools as good as possible and as efficient that it would be useful. And this is a key aspect that I think should be tackled in the future in terms of the education from the med schools in order to fully use the potential that digital health has.
Stefan, I know you're particularly interested in new and emerging technologies, for example, like artificial intelligence, AI, and machine learning. And working in reverse, i.e. Stefan and then Astrid and Julie, I'm just wondering, do you see those kind of technologies as being particularly useful in terms of supporting this hybrid care and hospitalization at home? And have you got experience of that indeed? Some examples?
Yes, thank you, Diane, for the question. Indeed, I think that it would be very useful for the medical personnel to have supporting tools for managing the patient. And speaking about these intelligent tools, when we go into telemonitoring for the patients, and we, like Julie or Astrid told, that they have a 24/7 system that needs to ensure patient management and monitoring. If we implement on these models intelligent systems that could track the patients and to determine abnormalities in their evolution, basically we could reduce the involvement of the medical personnel. Because not only in Romania, but I'm sure that also in Belgium, also in Netherlands, the medical personnel is very reduced in all medical fields. So somehow all intelligent models could support the lack of medical personnel that we are having at the moment. And in this direction, we are also involved in the University of Medicine and Pharmacy Carol Davila together with EHTEL in a Horizon 2020 project called VCare, where basically we are aiming to build a solution that could ensure telerehabilitation of cardiovascular patients, speaking about heart failure in our use case, but we have colleagues from Denmark that will do telerehabilitation with ischemic heart diseases, and also colleagues from Italy and from Spain that will treat neurological diseases, aiming by using an intelligent avatar connected and integrated with all the sensors that have been monitored previously, putting together also the contextualization factor, taking into consideration the weather, for example, taking into consideration the close environment of the patients, or taking into consideration the home environment by patient movement within the house and tracking the patients, together all this information to build a big data system that could ensure intelligent monitoring of the patient, auto-adaptation of his evolution of his activities in order to fully ensure his adherence to the medical therapy for preventive reasons. Because eventually when we speak about telemonitoring, we want to prevent hospitalization and getting the patient into another acute event or another entrance within the hospital. And we hope, this is basically the general idea, that by having an intelligent system, we would be able to decrease the involvement of the cardiologist, of the kinetotherapist, of the nurse, because somehow when all the patient profile, as it's introduced in the system, all the protocols should somehow auto-adapt and basically to inform and to take into get in contact with the medical professional only when we have problems.
Very wise, very wise. That sounds like really interesting experience with VCare, and we know you're making progress. Astrid and then Julie, is AI machine learning, and are these technical and organizational issues part of what you're doing in NWE Chance?
Well, within NWE Chance, that's not yet the case, but I follow the discussion on intelligent technology and artificial intelligence with great interest, because I also, like Stefan, think that these kind of intelligent technologies can reduce the burden of the care professionals. But also what would be of interest, for instance, when we are using the whole home hospitalization platform, if we could build in alarms, if we could use artificial intelligence to detect early signs of deterioration of the patient, that would be very helpful.
This is a great shopping list. I think of things to be researched and practically implemented. Julie, on your side, any preferences for how AI and machine learning should help?
Preferences, that's a good question. I think preferences, I'm a big fan of data, and I'm a big fan of big data. and I would use it to the fullest. And I think one of the great examples or ideas behind this is indeed that with this home or hybrid care model, we have access to data that we've never had before. So there is a giant pool of data and data points, to put it really mathematical, that we don't have in a hospital setting. So this opens a lot of doors. And I think Astrid also mentioned it very well, that things like smart thresholding are really the future also within this hybrid care model that should be integrated. And I also think that it is interesting when looking at this big data that we are going to search for patterns that we don't know of yet. So my preference would be to use it as much as possible. And I understand that there are a lot of concerns as well. But yet sometimes we also use our smartphones, we put everything on social media. So what could be the difference with using your data for a good reason instead of advertisement reasons?
Thank you, all three of you, for those very thoughtful answers. Particularly we in Europe know that there's a major consultation out at the moment, which is looking at the use of data, not only in telemedicine, but in health overall. And part of that aspect is how AI and how machine learning might play into that. So certainly we in EHTEL are focusing on what might be the potential good answers to give here. So we'd encourage all three of you and the audience as a whole to help us with that kind of input. I want to spend a couple of minutes, so each of you in reverse, maybe a minute or so, just thinking about on the economic side, and that will bring me to a kind of wrapping up thought, is in terms of the economics, what is it that makes this hybrid care economically viable for hospitals? What's the one main thing? And if you do care to have a reflection, one of our audience members has been really interested in what all this means, particularly in low and medium income countries, of which we have quite a considerable number also in Europe as well, clearly, as around the globe. Julie.
Also a very good question, and I think it's highly dependent on the service that is applied per country in order to get those reimbursements or to utilize this kind of care model. I do think that the key element is that it, of course, has a positive, not risk benefit, but a positive effect on hospitals, on their economical parts. But I think that the hybrid care model right now is still too much of it in its infancy to really know how to really shift those resources and how to put up the personnel at the right spots.
And Astrid?
Well, what is important in my belief, when I speak from the Dutch situation, what we know is what is really expensive are those square meters inside the hospital. Those are very expensive. What is also expensive is when a medical doctor needs to go to the patient very often. That's also very expensive. If you can shift that to go specialized nurses instead of a doctor, that already reduces cost. Also, the square meters of a patient's home are very less expensive than the square meters in the hospital. So what is important, and this is, of course, our calculation, but what is important is that you provide quality, either the same quality or better quality than in the hospital, with the same cost or less cost than in the hospital. That is for all countries important. And it depends indeed what Julie already mentioned per country, how does that balance look like? With respect to the questions regarding the low and middle income countries with a totally different healthcare system,
Yeah.
I think it's also of interest to have a look at that. I think that it also should be possible to do home hospitalizations over there. Last week, I joined a workshop, and there was a presenter from India who explained a great deal about telemedicine in India. And it was a very prevalent telemedicine and very well working over there. But of course, there are totally different situations. So you need to have a great look at what is needed in the country and how we can organize that. And I also hope that the innovation hub we will develop will also help people in those countries.
Mm. Thank you for mentioning that. There are many presentations from India at the present moment, but one of them was one done by EHTEL itself on the 20th of May that we're shortly about to make public, that did indeed have an excellent telemedicine speaker from India there. So thank you for that mention. In terms of low and medium income countries, one of the issues might be around the networks themselves and their availability. Stefan, I wonder whether you would like to reflect on what makes this economically viable for a hospital like your own in Bucharest, and whether there are any particular issues at stake there.
Diane, I think the discussion when speaking about the efficiency of hybrid care or home care, it's very extensive. As I mentioned earlier, the impact, it's clearly demonstrated in terms of medical outcomes. In terms of economics, as also Astrid said, if you travel to the patient, if you need to have also traditional interactions at his home or her home, probably the costs, it won't be a surprise to find out that the costs are almost the same. I would say that this is a key aspect in this relation is the fact that for the developed countries, probably you should take into account that there is another factor that it's related to patient's comfort. This patient's home comfort for his management is pretty important for most of them. If I would go and speak about the economic efficiency of these solutions, I would say that the economic efficiency of this solution would be really to have outcomes, maybe from our project, to have outcomes in terms of less or minimize at most the medical personnel home visits. It's important to have specialized nurses to be able to work and to handle and manage patients also in hospitals. We should take into consideration that also medical doctors are very reduced in number. For example, I speak with Romania. I'll tell you that we have hospitals around Romania that don't have a cardiologist. So taking into consideration this critical situation, it's as to say, a dream to speak about having hybrid care at home. I would say that in these regions, it would be good to have specialized nurses that could be in that hospitals. I have a hospital 50 kilometers, a city, not a hospital, 50 kilometers from Bucharest that doesn't have a cardiologist, where I'm going and I'm seeing patients because they don't have a cardiologist there, and I bring them to Bucharest for the ones that are seriously ill. So the reality for low and middle income countries somehow is this one. If we manage to build the digital solutions so intelligent that they could provide support for a medical practitioner, even if it's a doctor or it's a nurse or it's a diabetologist or whatever, and it supports him to cover more patients, that it will be useful. So for him to go one from 100 patients at home. But if he has to go, for example, to 100 patients at home, probably it won't work so well. So this is the idea related to the intelligent systems. And at the moment, if we would see to implement such a solution in the middle or low income countries, I would say, like I stated also earlier, that this part of education, this part of supra-specialization of the nurses, for example, if you speak about heart failure, or you speak about ischemic heart diseases, I think it's an important step to go in the direction of hybrid care. And for the low and middle income countries, these are the steps that should start being implemented at the moment.
Well, I think those are very thoughtful answers and very far-ranging, particularly because our audience come from many parts of the globe, Asia, the Middle East, as well as Europe. We do hope that those reflections are also going to be helpful to all of us in the audience. I would like to hand back now to George de Foulis, our chair, who I know would like to wrap up this very interesting session. Thank you.
Thank you, Diane, for chairing this interesting panel, and also the participants. So we had the privilege to have so many experts. Of course, we presented the European case study perspectives, but certainly these, especially like the last question, limited resources settings are not only in low-income countries. In Greece, for example, we have the Aegean Islands. In Norway, one of the richest countries, they have so scarce population, so it's there, and not even the most rich economy can handle the new healthcare costs which are emerging, and they are so expensive. So we had the presentation of how integrated care, ICT supported integrated care, can be used in chronic heart failure, about the organizational changes that the challenges mostly required. And as Stefan mentioned, it's not a problem of evidence anymore. We have so many pilots, especially for chronic heart failure use case, that proves that it's effective. It's the organizational, the economic, the business model you have to address. And EHTEL already has made work on this. You can visit our website, how we support, and we have a past experience and know-how to health authorities, to health insurances, to hospitals, through projects or meetings or workshops. So I would like to invite you to visit the project websites, and also EHTEL, and also to keep up this interesting debate during the next 2 days of these emerging technologies, which is going to be part of our routine care in the coming years. So thank you for your attention, everyone, and your participation, especially from the audience. So interactive. Thank you.